All right, welcome back to the Atlas of Chiropractic podcast. This is going to be an interesting conversation. Those of you that attended the Blair annual conference in 2022, where were we? That was in Dallas, maybe, or Orlando. Dr. Dania
South Carolina.
South Carolina. That's right. Dr. Dania Tamimi there in Charlotte was a presenter, and I think the connection is through Dr. Tyler Evans. Is that how you got coordinated with our group?
Yes.
Awesome. Okay. So Dr. Tamimi is a maxillofacial radiologist. And so I think he gave us 2 hours on CBCT and all of the different anatomical features and pathology and dysfunction and things that are relevant on that imaging that we as chiropractors either number one might not be looking for, or number two might not even know exists. So she took us to school, and you've also done some CE courses for chiropractors reading CTs. And I know you do courses for other professional organizations as well. So you're heavy in teaching, and I really appreciate that because it takes, someone from outside of our, little bubble with a fresh set of eyes to open our eyes to some of the things that, we may have been missing. So I appreciate your openness to share with our community and for sharing some time with me today. I think a good place to start would be just a little bit of background. Give us an idea of your training and how you got to being involved with the chiropractic profession.
All right. So I'm a dentist. I trained in dental school in Saudi Arabia, and I then went on to study radiology, oral maxillofacial radiology at Harvard School of Dental Medicine. And I did that in combination with a doctorate degree. So I'm a double doctor. And while I was going through dental school and while I was going through even my radiology training, I also had a parallel career in fitness. So I was an aerobics instructor, a spinning instructor, and that somehow took me into the world of yoga and Pilates. And I did it in a gym setting kind of thing, so group exercise classes and that sort of thing. So I always had an interest in how the entire body came together. And how it works together and how it functions and falls into dysfunction. And so like I said, a parallel career. And by the time I finished up my radiology training, I was like, okay, so which one do I choose? I was like, really heavily invested in both. And I chose the radiology, obviously, because it's just a more stable and lucrative field. I didn't forget the other world. Like I said, heavily invested. By the time I graduated from my radiology program, I had my 200-hour yoga certification, not radiology.
Many more hours than that.
A lot more for radiology for sure, but 200 hours for yoga. I also was Stott Pilates trained. I don't know if you guys know what Stott Pilates is, but it's the very anatomically and precise form of Pilates. The person, who created Pilates, was Joseph Pilates, and one of his disciples created the Stott Pilates philosophy. Okay. So anyway, so I had all that mat training, reformer, all that good stuff. And then I was like, okay, so what do I do now? Which one do I choose? And I chose the radiology because I also started to pop out babies, and it was hard to have it all, right?
Yeah.
So one has to make decisions. I still kept some of that in my life as I was going through my kids, kids diapers and kids lactation and all that stuff. Mm-hmm. I also had a one class a week kind of thing at the Y where I was teaching yoga and subbing Pilates and that sort of thing. So I kept that kind of interest in the two worlds. And I never thought that the two would come together, like, my radiology, oral maxillofacial radiology and that, until I met an amazing mentor by the name of David Hatcher, who's a radiologist up in Sacramento, California. And he basically gave me, I think, a gift, which is that knowledge about the TMJ, right? Mm-hmm. And the understanding of the TMJ. Not just as a joint that opens and closes your mouth, but really something a lot more central than that. It's what's responsible for the growth of your mandible and subsequently your face. It's what part of it is related to airway development. And there's a way that the two structures or the two rather systems come together and function together and fall into dysfunction together. So he really opened up my mind to all that stuff, you know. But then I was like, okay, so David, what about the cervical spine? And there was like a blank, right? And I'm like, there's got to be something. There's got to be something going on here. You know, when someone's jaw relationship changes or their airway is narrow, they're going to, you know, fall into some compensatory pattern, you know, to help increase their airway dimensions or to help them breathe or to function better. All right. So yeah, so that took me into a whole rabbit hole, you know, down the rabbit hole we go with, with all the possible continuing education out there. So David had an important role of bringing, you know, my radiology and connecting it to the rest of the body through the TMJ. But then there's the stuff that goes along, you know, with this deeper knowledge that one has to acquire to really understand the dynamics, the
Yeah.
biodynamics of the spine and, you know, and the contents and all that. And I can't claim that I know everything. I don't, but it's, you know, it's a journey. It's all of us. We are learning and we're all trying to find our way and find the truth, about our, you know, the structures that each and every one of our patients have. And yeah, and there are so many different philosophies and different ways that these structures come together and philosophies on how to treat the dysfunctions in these structures. So I try to like acquire that. Like I'd like to think of myself as an aggregator, right? Like in
Yeah.
orbits, and I'm collecting information here and there from you guys as chiropractors, from the osteopaths, you know, from you know, the anatomists, from the ENT docs, from the head and neck radiologists, you know, medical radiology, from the different disciplines in dentistry, and just trying to bring it all together. Because in the end, you know, I'm responsible for what's on the scan.
Mm.
And the scans that I'm looking at are the head and neck, right? So from the pretty much where the hyoid is, C3, C4 when it comes to our world in dentistry,
Mm-hmm.
and upwards. So I need to understand what lives in these areas, not just the hard tissues that we can see on the cone beam CT, but also the soft tissues. So that's a little, maybe a bit too much information, but
No, it's perfect because you know, if you didn't have that fitness and Pilates framework that you view health through, that question of what about the cervical spine may not have been, you know, on the tip of your. I was impressed when he said, well, you know, doc, what about the neck? Because we don't always see that in reverse in the chiropractic field. You know, we don't always see folks go, oh, I've learned so much about the upper cervical spine. Like, what's going on with the jaw? Right? It becomes like, well, look what I know about my thing. I figured a lot of stuff out here. And so I think that systems approach, to use your word, of understanding anatomy and how, you know, these structures are not isolated out into, you know, they're bits and pieces that act independently of each other, but it is a neurostructural system. And then the, you know, soft tissues, you bring that into the picture, there's a lot of dynamic uh, anatomy and physiology going on from the shoulders up, right? And it's almost a disproportionate amount of interaction compared to some other systems in the body. So it's fascinating, and it's the logical next step. And I appreciate when folks think a little bit outside the box that way, because it creates opportunities, right? Just kind of like cracks one door open, and then, like you said, down the rabbit hole you go. And you've done that for a lot of chiropractors, you know, even being able to just introduce us to some of the important anatomy and dental concepts, you know, for upper cervical chiropractors. I think a lot of us we're curious, right? We love looking at our imaging. We want to help our people. We're curious about how it works. So even just kind of tipping that first domino, especially for a person like Tyler Evans or Michael Beebe or some of the others that you've interacted with, it's a really good thing, and it produces a lot of fruit. So I appreciate your curious mind. I think a lot of people that do interesting things in healthcare just have that curious mind. You know, they're tinkerers and they want to just do what you said, see what they're doing over here, piece it all together. And we need the curators and the aggregators, because those of us that end up getting really, really hyper focused in an area sometimes lose sight of the forest for the trees.
Absolutely. And you know, it's a common affliction in medicine and in dentistry and actually in humankind to like to
Mm,
look at the things that you like to look at, right?
yeah.
So, I mean, if I were to bring you into my clinic, you know, and look at you, like if I'm looking at you right now, I'd look at your face in a very different way, and your body, of course, in a very different way than if we're another chiropractor that was looking at it.
Mm-hmm.
There are things that my eyes are going to pick up right away, like if there are any cavities or gum recession or anything like that. So you better brush your teeth before you come and visit me. So yeah, there's a lot of things. I mean, as human beings, we tend to look at the things that we like to look at, and that's just the tunnel visioned approach to our lives, And when it
Yeah.
comes to our practice, unfortunately, in dentistry, it's the same. People will look at the thing that they want to look at, but they'll ignore everything else. And when it comes to teaching people to read cone beam CT, that's an approach that I ask people to take. Whatever it is that you want to look at, whatever it is that the patient came into you to see, just don't look at that. Okay. Make that the last thing you look at. Look at everything else and do that systematically. And then go into the thing that you want to look. Because once you look at the thing that you want to look at, you're going to check a box and that's it. That's going to check a box in your head and you're going to move on. But if you keep your mind curious about that thing and still go through everything else systematically to make sure there's nothing else there in any other place that you're not interested in, then, you have a comprehensive picture of what's happening with your patient. Mm-hmm.
Yeah, that's great advice. And I think I may have you maybe just describe how you would go through a scan. I did I think Vivos had like a 2.5 hour, CBCT free online thing that I watched I forget the doc's name, but he had kind of described the way that he scans through CTs front to back, top down, however you want to do it. What would be best practice? Give us an idea of how you would, as a chiropractor, assuming that like my main focus is the spine, we're going to set that aside. How would you approach a CBCT scan?
Okay, well, first of all, everybody does this a little bit differently, and it doesn't matter which method you adopt as long as you stick to it. So you
Mm-hmm.
have to find a systematic method that you're going to adopt that is going to that's going to enable you to go through every single structure. My method is maybe different from, the people at Vivos, the other radiologists. Everybody does things a little bit differently, but in the end, it's just that consistency and the high fidelity, in approach between one scan and the next. Okay,
Yeah.
because everyone has the same anatomy,
Yeah.
with variations. This is so I'm going to be a little bit philosophical right now. Underneath your skin, you all look the same. You all have the same. There's, no, I can't tell if you're black or white or yellow or whatever, underneath when I get your cone beam CT. So that's just something a little humbling. And, anyway, that was.
I know you're 100% right. And I remember even in chiropractic college, I think one of the docs that taught us to read bone films, he even said like you couldn't even tell if this person was alive or dead. Like all you're looking at here are bones. This is a part of the whole, and that's what you're
Mhm.
referencing too.
Right. It's a cross section in time. Like you said, you don't know anything about this person other than what's there.
Mm-hmm.
So
Yeah.
anyway, yeah.
Good. Well, so and there's a lot there, right? And I know that
Mhm.
I have an affinity for dentistry. I went through undergrad working and interning in a dental office, basically worked as an assistant with the intention that I would go to dental school. And so that was so my introduction to healthcare was, at the side of the dental chair. And I worked in this old rural, country office. This guy didn't even have a computer in his office. Everything was done, the way that he started in 1972 when he graduated from Case Western. And so I was in the dark room dipping his periapicals and his panos and all that stuff. And it was he would point things out on these black and white grainy x-rays, and because he'd been looking at them for 40 years, he had this enormous database in his head of these images and what to appreciate and what to notice. And I've studied anatomy, and I was sitting there in the chair with him looking in these mouths, and I thought, I can't for the life of me see what he's seeing, right? So technology's evolved so much that now we're confronted with these high resolution, high quality images that are really readily accessible in a matter of seconds.
Mhm.
Um, Maybe explain how you got introduced to CT. When did that become sort of a uh, useful modality in dentistry? Because in chiropractic, it's only been, I don't know, maybe a decade of utilization here.
Right. Well, the history of cone beam CT, it goes back, it started off in medicine, and they actually started using it for cardiac imaging. Don't ask me how, because cardiac is soft tissue. But anyway, so it evolved to becoming an imaging modality in dentistry. And in around 2000, approximately the year 2000, okay. And then while I was going through dental school, there was no cone beam CT. So I graduated from dental school in 99. And then I entered my radiology program in 2000, from 2000 to 2005. So we didn't get our cone beam CT until towards the end of my program. It was already 2004 or something like that, beginning of 2004. So that said, I did a lot of training at Mass Eye and Ear Infirmary in Boston, which is Massachusetts Eye and Ear Infirmary is like a big hospital that does a lot of ENT stuff, and the radiology department there sees all those images. So I already had that ability to think three-dimensionally from going through all those CTs and MRs in the medical setting. So now here we have cone beam CT, and at the end of my program, I'm like, okay, I'm now scrambling trying to figure this thing out, because like it's something new, right?
Yeah.
And I guess it's an evolution. It took some time for me to actually get really good at it. And in the beginning, everybody's a little rusty, or not rusty, but rather, you're hesitant. And it takes you some time to develop the proficiency that's required to do this, with ease and with confidence. But I'd say within like 1 year into my practice, independently, then I started to be like, okay, now I'm ready to go. I can do this. But remember, I had all that training in 3D. It's not like I just was thrown into the world of 3D from nothing.
Right.
So that's in dentistry. It's pretty much been used since 2000, little bit by little bit. It didn't really permeate into the market until I'd say 2005, 6, 7, something like that. Then it exploded, and the cone beam CT vendors were selling it to every Tom, Dick, and Harry, and that's basically how it went, because there's no restriction in the US to who can buy a cone beam CT. I mean, in terms of like dentist, there's no, like in Canada, for example, you can't have a cone beam CT unless you go through a good amount of training in both radiation physics and biology safety, basically, as well as in interpretation. But we don't have this here in the US, which is kind of alarming, but
that is interesting. And I've always been curious about those medical legal differences, even on a state by state basis, let alone, across borders. But, I guess we all sort of lean on our educational institutions and say, what are they doing with this, and what are they teaching with this? And in cone beam CT with chiropractic, this is, literally there's just in the last 18 months or 2 years that there's been a cone beam CT on a chiropractic campus. So we're in the early stages of, going through that regulatory process of understanding what is the best practice for using this imaging in a chiropractic setting, and, what is the relevant training, so that folks can use it appropriately and safely and for the right reasons. And so it's, these things, history repeats, as technology emerges, but the access is becoming so much easier that, like you said, it's kind of at this point hit a tipping point in upper cervical chiropractic, and it's kind of like the go-to thing that everyone's excited about right now. So we are kind of playing catch up a little bit, because, like you said, you had all that training in 3D, and some of us, we have some, right? We look at MRIs, we look at advanced imaging in school, and then we see them with patients periodically, but we're not scanning through as much anatomy on imaging as you would have in your radiology training. And so now we're kind of getting this new tool. It's big time 3D, and I think we like to think, as chiropractors, we like to believe that we think in 3D, but it's a little bit different. It's a little bit different way of viewing the anatomy in the system. So let's maybe start with the TMJ, but I'd be curious to review a couple systems, and you can kind of give us an idea of, as upper cervical chiropractors, the importance of these systems relevant to our practice, and just from an imaging perspective, what things we need to be looking out for in there. And TMJ, Airway, and then if there's anything that you'd like to say about the sinuses, orbits, any of those like internal skull features too.
Mm-hmm. And that, I mean, actually, let me start from the more dental thing. How about that? So, because we're taking us away from the tunnel vision and then things that we're interested in, and I'm going to talk to you about things that you may not be interested in. So we'll start with that first, okay? So, dental caries and periapical inflammation and periodontal inflammation, all that stuff is like the most common inflammatory process happening in the patient in humans. You know, of course, we have colds and that sort of thing, but radiographically, you're going to see a lot of dental inflammation. So the sequela of decay or other issues that lead to pulp death, that lead to a periapical rarefaction, so an inflammatory process, pus, whatever, in these around the apices of the teeth. Okay, and these may be painful if they're acute, if they're early on, or they could be chronic, and this person may have this for a long period of time in their body, and we all know who wants inflammation in their body, right? So, and of course, in addition to the fact that we might have in these patients, there may be benign or malignant tumors in their jaws, okay, as you may have benign or malignant tumors anywhere else. But I think it's important, since a lot of, and I've seen quite a few cone beam CTs coming out of chiropractic offices, they do include the jaws, okay? So I think it's important to establish a method to look at the jaws to rule out the presence of either the inflammatory processes or something a little bit more sinister, to make sure that, you know, you get the patient to where they need to go. And this is not about like, okay, it's not my thing. I'm not a dentist. Who cares? You know, I'm going to just have the patient sign off on a waiver, because dentists do that, by the way. They'll say, I'm only going to look at the thing I want to do, and I need to sign this because you can't do that. And that's not going to hold up in the court of law, right? So you just have to, and it's not about that. It's about the karma, right? It's about you and the relationship with another human being that trusts you, right? So you need to be able to tell them if something's wrong, right? And if the information is on your scan, you better find it. So anyway, so there is a methodology for looking at the scan. I mean, like I said, everybody is a little bit different in the way that they look at things. But the way that I do it, I simplify it for people, is to look through the scan from the axial, from the top, okay, and then take it all the way down. And when you're looking at the axial, you're looking at only the black things, okay? So your eyes can only pick up, or are better apt rather at picking up variations in these grayscales if you're focusing on one grayscale level, all right? And air is black, right? So you look at the black stuff. You look at the sinuses bit by bit, each sinus on its own. You know, you're scrolling up and down through the sinuses, through the nasal cavity, through the nasopharynx, the oropharynx, all the way down to the bottom of the scan. Okay, so that's airway for cancer screening. Okay. Now, when I teach this to dentists, I tell them to climb up the cervical spine, because they don't care about the cervical spine. So climb up the cervical spine, the white things now. You're looking at the white things from cervical spine upwards into the skull base, looking at all the foramina, and then taking it all the way to the top, right? And then in the dental case, now we're going to look at teeth, all right? So the teeth, for you as a chiropractor, the way that I would ask you to look at it is going to be different from what a dentist would do, because the dentist is very particular about each tooth, and there are different things that they're trying to figure out from the cone beam CT than you. You just need to make sure there's no pathology. So when you're approaching the teeth, when you're approaching the jaws, start with the axial, okay? And you're starting from the top down on the axial. And I'm hoping that you know how to count teeth, or at least if you can't count them, at least you know their names, right? So, and you look at it just like a dentist would, you know, so you're looking at from the right side, okay, the upper right across to the upper left, and then you go down to the lower left and across to the lower right. Okay, so that's the methodology of looking at these. And on the axial, as you're scrolling down the roots, you want to look for any changes in the periodontal ligament space. So I wish we could, like, I could show you a diagram, but, you know, I'm going to try my best to be as verbally descriptive as possible. So your teeth are these calcified structures, and the roots are conical, right? Or semi-conical. And in the center of the root is going to be a low density area, which is the pulp. All right. Because it's soft tissue. And on the axial, that's going to look like a little hole or a circle. Okay. And then around the root, there's going to be a low density line, which is the periodontal ligament space, which is where the tooth connects to the bone, right? And around that, there's a white line called the lamina dura. And that's just what that configuration looks like normally. Now, as you're scrolling through the apices and the roots of the teeth, you're looking for changes in widening of that lamina dura, okay? Of that, sorry, periodontal ligament space, that low density area, okay?
Right.
Right. And it's quite easy to do, you know, to pick up things that way. Also, the other thing you want to look at after you finish looking at the teeth is you want to look at the outlines of the bone, because every single bone should have a cortical outline. So that's
Right.
a high density, thick, relatively thick, depends on the bone that you're dealing with, but it's a hard tissue, dense structure. And then inside we've got trabecular spaces, and the trabecular spaces have these marrow spaces. They've got trabecular bone, okay, but the majority of it is soft tissue. So it's lower in density than the cortical bone. So what you need to be doing is you need to look for the continuity of the cortices all the way around to make sure that there are no breaks, okay? And the other thing you need to look at is, do these trabecular spaces, these marrow spaces, are they uniform? Are they homogeneous? Or are there areas of high density or areas of low density that may signify the presence of pathology? So yeah, so that's the teeth, okay? Now we can go on and talk about other things, but if you need to like interject with anything just to break it up a bit, we can go ahead and do that.
No, well, one thing I was thinking is, as this is an audio recording and you said I wish I could show you, images. I'm going to just tease this. We'll talk about it in a bit, but I'm going to encourage folks to go get Dr. Tamimi's book, because you've got a book with, all of these structures outlined, pictures of scans, all the anatomy, all the relevant, because I was thinking as you were even talking about the, in the soft tissue spaces in the airway and looking for, lesions and masses. I can imagine some folks going, well, I don't even know what that looks like normally. So how am I going to appreciate an abnormal scenario? And I would encourage you to go pick up her book, and have that as a reference guide and have something to study these anatomies. And I would, if I were doing it, I would just choose a system, right? Start with the teeth and study the chapter on the teeth and start looking at all the teeth, get that memory bank built up, and then go on to the next thing. It's impossible to absorb all this information, all at the same time at once. But I think it's reasonable the way that you described it. Most folks should be able to visualize, those changes. So I'm with you.
It took me 23 years to get where I am right now. So it doesn't happen overnight,
Well, and that's the sign of an expert, someone who's strong in an area is you can take a complicated situation and describe it simply like you just did. So, kudos to your, to your years of dedicated training, because it shows.
Thank you. Thank you. All right. So continuing on to the other systems, do you want to talk about Airway next? We can talk about Airway.
I think a lot of chiropractors in particular are interested in the airway right now. And I know, just thinking about a cervical lordosis, right? A lot of us get really fixated on measuring these, these spinal curvatures and making it a treatment outcome that we want to see those things improve. And I remember, I don't know if it was at a chiropractic conference or a dentist friend of mine or somebody that had, kind of, put the bug in my ear that, you're the most important thing in your life is your next breath, is what he said. And it's like, your body will trash your neck in order to open up that airway and provide volume for respiration. And so, when we think about even our anatomy and our outcomes and things that we're, interested in, it's really important to understand these other systems and their interactions, because, you don't want to put somebody in traction or, some sort of like extension traction type position to increase that airway and get frustrated when the outcomes don't improve or when neurologically they don't do as well, because they're, you're trying to decompensate. So yeah, let's talk about the airway, because I think that's on a lot of folks' radar these days.
Okay, so this is a multifactorial structure or set of structures. Okay, so it's not just about the oropharyngeal dimensions that are, by the way, as you said, manipulated by the posture of the head and the neck. All right, there's a lot to it. So your breath actually starts from the tip of your nose, right? So everything from that point on inwards, all the way down to your hyoid, is implicit in this sleep disordered breathing thing. Okay, so you need to look at the nares, the internal nasal valves, which are basically, you've got a cartilaginous structure, two cartilaginous structures that come together in the lateral aspect of your nasal cavity, of your nose, actually. And if there is a collapse of those structures, that's going to narrow the internal nasal valve, which is going to compromise your ability to breathe in and out through your nose. Okay. Now, further in, when you go into the piriform aperture, which is the hole, that it makes up your nose, if you take all the skin away, right? The hole in your skeleton, in your skull.
Yeah.
So you need to be looking at the size of the turbinates, the presence of anomalies, the deviation of the septum, septal spur formation, the presence of pathology, rhinosinusitis, that kind of thing. When someone's always congested and can't breathe through their noses, they're going to breathe through their mouth, and that's going to introduce a whole other bunch of issues. Okay.
Right.
Things as further back, we have into the nasopharynx, we have the adenoids, okay, which is lymphoid tissue that lives in the back of the nasopharynx. And that can enlarge, especially, children tend to have large adenoids and tonsils, but in some kids, they become so large that they will occlude the back of the nasal cavity, the posterior coina of the nose. Okay. And then the kid is going to resort once again to mouth breathing. As we travel down into the oropharynx, there are several collapsible structures here. We've got our soft palate, we've got our tongue, we've got the epiglottis, and of course we've got the cervical spine and the prevertebral tissues posterior to that. Okay. And the face, or rather the jaws, is the house of the tongue. So the tongue has to fit in that house. And if it doesn't fit because of the phenotype of that person, okay, because their arches are narrow, because they've been breathing all their lives through their mouths, and they've taken their tongue away from the palate, and there has been a whole bunch of remodeling changes in the face that make that tongue, make that actually the house of the tongue much smaller than the tongue. The tongue's going to go back, right? Yeah. So the oropharyngeal dimensions is an important factor here, but on cone beam CT, when you create a volume measurement of that, you have to understand that that volume does not represent what happens to this patient when they're asleep, because the scan is often acquired upright and when the patient's awake. And when you have sleep apnea, you're asleep and you're lying down on your back, right? Yeah. So there's that. And then, of course, the fact that the patient might manipulate their head during scan acquisition, for stabilization. Now, I know that in chiropractic offices, you have a head clamp and you're actually very cognizant about having the patient in a natural head posture, right? However they present clinically, in right. life. In dentistry, it's not like that. They don't care about the cervical spine, so they'll often put the chin on the chin rest, bringing the patient into a forward head posture, or maybe they'll take the head back and strap the head back with Velcro, bringing the head against the headrest, and that's going to make the airway dip smaller. So, and of course, tongue posture, depending on where you put your tongue, that's also going to manipulate the oropharyngeal dimensions. So you have to be just wise about, interpreting what those dimensions really mean, because they don't really correlate unless you look at the clinical presentation and start to figure out what else is going on. Because like I said, there can be other things which are very easily detected on cone beam CT that we need to be aware of. Because you can't treat something if you don't diagnose it. Yeah. Right. If you're like, airway issue, and then, okay, let me increase the cervical lordosis to increase airway, but the issue is in the nose, yeah, or the issues in the jaws, then you're not doing anything. You're just masking an issue. Right.
Yeah, it just becomes one more fixation. The next thing that you hyper focus on. And I really like troubleshooting. I think a lot of us that get into upper cervical care, we like that problem solving part of it, which is we don't just treat everybody the same. And I was thinking as you were describing, those relative relationships, even with alignment and misalignments, we don't necessarily adjust every little thing that's misaligned, because in the whole picture, it may or may not be relevant. And it's about figuring out the cause and effect type relationships there. So I think the philosophy is very similar. and the way that a lot of us approach, even just the osseous part of the scans. But it's worth having that top to bottom, front to back, three-dimensional perspective of airway, because I think what a lot of chiropractors, and I've been guilty of this too, think about the airway, they just think about that retropharyngeal space, and they don't always consider all the way up to the tip of the nose. So even just that bit right there will really help folks expand their perspective.
Right. And remember, your sleep disorder breathing isn't just obstructive sleep apnea. You can also have
Right.
central sleep apnea, and that's a whole other ball of wax. That none of us are, neither me or I guess chiropractors are qualified to diagnose or treat. So
Yeah.
yeah. So
And then
diagnosis is key. Mm-hmm.
and then the TMJ themselves, and this is something that I think I'm personally, and I know others have shared the sentiment. It's like when you talk to dentists about what's important and what systems and diagnoses are relevant for us to be paying attention to. It's like I've heard everything from it's all about occlusion, and the TMJ doesn't matter as much, fix the occlusion. I've heard other folks say that the airway is the most important thing and we don't really care so much about the joint, and other folks say that if you don't fix the joint, the occlusion in the airway will never improve. And obviously they're all related, but there are differences of opinion in dentistry about how to prioritize those structures. So maybe you care to weigh in on that. I know you don't have a clinical practice where you're treating patients, but when we're looking at imaging, we're going, oh my God, this person's obviously got symptomatology of someone that has dysfunction in these systems. How do I prioritize this anatomy? Do you have any input on that?
Well, first of all, I want to second the fact that you said that there are different ways of approaching this. Yes, there are multiple ways of approaching it, and they don't always agree, and they don't always talk to one another, which is a problem. They're just so wrapped up in their egos that they don't want to communicate with the other party. When I think that there is truth in what everyone is doing, and our systems are just so malleable and so apt to repair themselves. They're just so well adapted to do that. That anything that we throw at them they'll take, and they'll in some cases, of course, it doesn't work out, but in a way, there are many ways to skin this cat.
Yeah.
Right. Okay. This cat scan.
Nice. I just got that. That's good. Yeah, and it's true. We all in chiropractic, it's the same. With chiropractic techniques, and we all have our interests and our priorities. And you're right. I think at the root of it, we do have to appreciate. And this is one thing I like about chiropractic, is our philosophy does sort of identify the body as an adaptable, self-healing organism, where these systems will coordinate, and the progress you make in one area often translates to progress in other areas. But that doesn't mean that those other areas, aren't don't warrant further investigation in and of themselves.
Mm-hmm. Yeah. So I think the first thing I'm going to tell everybody on this podcast, listening to this podcast, and everyone who I get a chance to talk to, is do away with the ego. Right? And open up your eyes and open up your ears to what other people have to say. So with that said, okay, so let's think about what the most important thing, and you already said this, you need to breathe. So we need to make sure that these people are breathing, because it's not just about the inhale and the exhale that you're taking at this moment, but it's also the long-term effects on what that reduction in quality of sleep will do to a person. And if this has been happening all their lives, ever since they were kids, that's going to manifest as so many different chronic diseases. I mean, if they make it through teenagehood without falling asleep behind the wheel,
Yeah.
So, and ADHD and all this medication we're throwing at our kids, just to get them to be, and I'm using my fingers as quotation marks, normal, right?
Yeah.
When in reality, I mean, many of these kids and adults just need a good night's sleep. And we've all had these nights where we didn't sleep well and we just felt really bad the next day and couldn't function and all that. Just imagine this happening chronically over your entire life. So I'm going to give a book recommendation. This is actually, it's a paperback, it's a really good book. It's called Why We Sleep by Matthew Walker. Yeah. So I don't know if you've heard of him or not, but he's this brilliant neuroscientist, who's made it his life work to study sleep in humans. And he's a great writer and he's a great orator as well. And I think he has some podcasts with Peter Attia. I don't know if you know Peter Attia or not,
Yeah.
but yeah.
Mm-hmm.
So you can look him up and just listen to what he has to say. It's going to give you an appreciation for the importance of sleep and make you a lot more protective of your 7 to 8 hours a night, right? And then you can relay that to your patients. And the nice thing is this book is so easy to read that you can give it to patients to read if you think they have an issue. Okay.
Excellent.
So going back to the prioritization of what to do. I mean, you can't do it all. You in your silo upper chiropractic world can't do it by yourself. You know, you need to be talking to other people and work as a team. So if you have patients, if your practice does have a lot of TMD patients or a lot of airway patients that you are suspecting have sleep disordered breathing, that is, you might want to talk to or create some liaisons with the sleep dental medicine people, as well as any TMJ specialists in the area. Okay. All right. So I'm going to take it now to TMJ. And let's just say that this is like probably the most contested piece of anatomy in the entire body because, you know, once again, there are many ways to skin this cat and everyone thinks they're right. Okay.
Yeah.
There are some that will focus on this joint as being, or the issues with this joint being a product of psychosocial disorders. Okay. So stress and abuse and all that trauma, whatever it is. Okay. So it's all in your head and they're going to medicate you and maybe put a splint in, you know, if there's like excessive muscle bracing because of bruxism or whatever. Okay. And there are those that are going to say the TMJ and the occlusioner are linked to one another. And we need to make sure that there are no occlusal interferences, no high points, nothing like that could be causing the patient to over clench because they're bothered by that. Right. Mm-hmm. So that you've got these two philosophies and there are more, of course. Okay. And they don't want to talk to one another, or maybe that they just don't believe in what the other one has to say, because one is looking at it through their lens, okay, and saying, okay, so show me the evidence, show me the science, show me the whatever, you know, there are no like large randomized studies that show that the TMJ, that the occlusion caused temporomandibular disorders. But then there are the clinicians who are wet-fingered dentists who are seeing this every day, right? And it's really hard. It's a hard thing to study. It's a hard thing to study and to put into a paper. Yeah. So then you come into another realm, bring the airway in. Okay. So which came first, the chicken or the egg? You know, yeah. Did the airway issues start first or did the TMJ issues start first? And how does this all relate to the occlusion? There's just so much to it, right? Yeah. And then let's throw in the cervical spine, since we're all, you know, interested in this. And this is something that most dentists don't even have a clue about, you know, is that especially, you know, in orthodontics where they're changing maxillary mandibular relationships and influencing people's growth, the facial growth, what's going to happen downstream to that if they change the mandibular maxillary, relationship? The fascia, myofascia is going to respond and there's going to be changes in the way that you align your spine, right? Just a simple thing. And I mean, I know that people can't see me here, but let's do this, you and I together, and hopefully they'll follow along. Okay. So just sit up tall, and everyone can try to do this as well. Sit up tall and bring your teeth gently together. Okay. So don't clench, just have them touch lightly. Okay. And keep your eyes level to the horizon. Okay. Now I'd like you to tip your nose upwards and notice what's happening in the contacts between your teeth. And then tip your nose downwards and notice what's happening in the contacts between your teeth. And I'm just talking about capital flexion and extension.
Yeah.
Okay? So what do you notice?
You feel it slide back and slide forward.
Right. Okay. So just imagine that there's this person who has a sleep disordered breathing issue and they have the cervical lordosis, right, or a forward head posture where they're trying to increase airway dimensions. So what type of posture do they have with their C1, C0? I mean, what do they have? What's going on there?
Extension, yeah.
Extension. So there is a situation that they're in habitually, which brings their mandible back. Right? Yeah. Now, most dentists will just like treat the patient wherever they are. They're not going to think about these relationships, right? So this is something that, I think there's a role for the chiropractor to come in and to help, chiropractic physical therapists, osteopaths, whatever, any people who understand the role of the whole body and the myofascia and how it all plays together to help create proper and successful long-term outcomes for dental patients. Okay.
Yeah, and we see folks that the other thing that is important to remember is that folks can have more than one issue, right? And we see a lot of folks that have had cervical spine trauma and they've got an atlanto-occipital articulation misalignment, and that's stress to the joint capsule. When that thing is moving around without proper alignment and mechanical motion, and that's not healthy for that joint. If you add on to it, this relationship that you're talking about, and creating extra extension stress in that joint when it's already dysfunctional. I mean, we were just learning about some craniocervical instability situations, and one of the doctors, Dr. Chris Centeno, an MD, who does a lot of the biologic injections for creating stability in the CCJ, was talking about how we're realizing that occipital-atlantal articulation instability in that joint is a huge problem. You develop rotation there where it's not supposed to be. That's a huge pain generator for a lot of these patients. And so even just that bit there, understanding how the occipital-atlantal relationships will be manipulated by that airway and TMJ relationship. It's the review of systems, right? We have to really be screening all these relevant systems. And the way I kind of describe it to patients is what you said before. In my silo and in my area of expertise, I can help you in this way, but we also need to be mindful of some of these other issues that are going to, number one, limit how successful we can be with our treatment approach, and number two are going to be feeding into your symptomatology. And the idea is that we want to work together to get the best possible outcomes, not just objectively with our indicators and our treatment goals, but symptomatically as a person. You had referenced this before. As a person caring for another person, we want them to feel good and live a high quality life. Right. And so even these little things that I hope folks are thinking about, how does this relate to, even the way that I analyze my chiropractic outcomes, and piece these things together, because I do find, the dentists that I've met with, even though they may have differences of opinion with each other, they're very keen on, what do you know about this neck deal, and how's that going to impact, both their outcomes, but also things that they could be looking out for. And so we've even had conversations about physical exam procedures and things that you can look at on the CTs in the reverse, of that conversation.
Mm-hmm.
So,
Someone that you might want to interview maybe next time or even have a conversation with is Mariano Rocabado. Have you heard of Rocabado?
No.
Okay, so he's a physical therapist out of Chile. He speaks good English, very good English, because he did a stint here in the US. And he is brilliant. And he basically talks about the relationship of the craniovertebral junction with the occlusion and with the TMJs. Okay, and he has this concept called the tricentric concept. So tricentric concept is the occlusion isn't just TMJs and teeth. It's also where your atlanto-occipital joint is. Okay, and he actually wrote a chapter in my book. If you get the book, it's there. But you can look him up, and if you'd like me to connect you with him, I think this would be very helpful for your group, because he really is. He's a very nice person too. He's an amazing person. He's a good friend of mine, and very giving in terms of his information. So,
Yeah, no, but I think that that's such an interesting perspective, and just visualizing the structures, and even whiplash mechanics, and how the whole head and neck are traumatized by some of these injuries that happen on a day-to-day basis. Let alone your phenotype, like you described, let alone, whether you were breastfed or bottle fed, whether you were a cesarean or natural, all these other factors, right? I feel for folks. They've got so many things that are layering dysfunctions, in these systems, that honestly, I feel that as upper cervical chiropractors, like we need a comprehensive approach to managing these conditions. And for a lot of us, we'll probably be the one to consider the relationship first, right? It may not, because we know that, folks aren't going to the dentist like they need to. they're not brushing and flossing like they need to, right? So even just picking up on the dental caries, but then looking at these other systems, they may have not been in a dental office for years and have had
Mhm.
anybody screen their TMJ, even with just physical exam procedures. So I think we have this kind of interesting niche where chiropractic is I guess a little bit more familiar to folks, and they're a little bit more comfortable with it, and that now they're understanding the impact on, let's say things like headache and dizziness presentations, which obviously, all these dental concepts, blend with really nicely. Yeah, I love having these conversations and this networking. I would appreciate the introduction to Mariano, because I feel strongly about being the mouthpiece, right? And that's kind of like pun intended, but these conversations that happen that should elevate all of our understanding and our level of curiosity and our diagnostic prowess, I think is crucial for sort of the, for lack of a better word, just jacked up physiology that these poor folks are bringing into our offices.
Mhm.
And I heard a guy he's not a chiropractor, he's a chiropractic advocate and a marketer and researcher and that kind of thing. And he said that recently, patients bring more to the table than what you can do for them on the table. And these conversations that we're having are really, really, emphasizing that point, even just, from the hyoid up, right? There's so much going on there. So I love these conversations, and we could go on and on. But is there anything else you want to mention as far as the TMJ before we start to wind down? I know we could. It's hard in this amount of time, to describe all the relevance. But anything else you'd like to mention in that topic?
Well, actually, more along the line of how you can create a relationship with a dentist, and I think it boils
Sure.
down to you picking up dental disease.
Yeah.
So if you learn how to pick up dental disease and you start referring your patients to a dentist, they're going to be like, "Oh wow, you exist. What are you again? Who are you?" you know. And
Yeah.
then you can take this dentist out to lunch and start talking to them, or about what you do, and they'll start referring patients to you, right?
Yeah.
So that's just something.
Absolutely.
Yeah, and then you can get into these deep, because not every dentist is really down with all these deep relationships of all how everything is connected to one another. Still, the vast majority of them are drill and fill, right?
Yeah.
Are
Sure.
still doing the basic dentistry, okay? But a lot of them are niche dentists and high functioning dentists who will take it to the next step, okay? I think there's one dentist who practices something called chirodontics. I don't know if you've heard of that or not. Yeah,
I have. Yeah.
I don't know anything about it. I just thought the name was sketchy. So,
Yeah, and it's I think the average I can appreciate where they're coming from, but I think the average person would be like, is this guy an orthodontist or a chiro, or like what's going on there? So I got to get with that guy and see what he's about.
right,
But
okay. So I
good
guess
deal.
that's it. And thank you very much for the opportunity to share some of what I have with you.
I appreciate you being willing to do so, and I know I kind of put you up against the time crunch here with 45 to 60 minutes to cover in depth or even at a surface level, all this important anatomy. My intention and what I hope the listeners are going to walk away from this conversation with is a piqued interest. Just understanding there's a lot more to be gained. By kind of slowing down, taking a step back, and looking at this anatomy with a more critical eye and with a little bit more of a filter. That is sort of from a different perspective. Not a chiropractic perspective, because we share a lot, and I think this is what's really unique about when folks like you come into our community. We really care about function, right? We're mindful of the pathology, but we want folks to function well. We want them to have the best quality and quantity life through proper function of the neuromusculoskeletal system, right? And then that encompasses all the others too. Patient centered, right? We care about people. Like a lot of us that get into these fields, it's not because we picked upper cervical chiropractic off a career fair job description in high school, right? We find ourselves in these interesting fields because we care for people and we're curious, and it sort of meanders our way on these journeys, and health and fitness, healthcare, all this stuff, it kind of comes together, right? And then the last part of it is the open-minded and collaborative mind. I think a lot of us are really, we're really keen to help each other, right? Not just as people, but as healthcare providers. And we see folks that are suffering in our clinics, and we're motivated to be a conduit, for these folks to find help. And so I really appreciate you being willing to share a bit of your expertise. I would love, if you have a few more minutes, talk to us about this book. I mean, holy smokes, what an undertaking it is to write a reference text. Just as a side project, you mentioned you're a mom and you're a health enthusiast and you're a practicing radiologist. So how do you find time to just throw together a textbook on the side?
Passion.
Mm.
So, and lack of sleep, since we were talking about that. No, but honestly, early on in life, it was early on in my professional life. Remember, I work in private practice. I work from home, so that's it was very challenging to raise young children and try to keep some semblance of my professional life, because there's no clocking out. There's like, I'm here all the time in both capacities with all hats on, right?
Yeah. Yeah.
So I'd like to say that I was fortunate enough to run into some amazing mentors who imparted many gifts and parcels of knowledge upon me, and these books, I would like to think that they are a tribute to them. Okay, so I have 3 books. One of them is oral maxillofacial, just the pathology. It was actually the lead author is a good friend of mine, Lisa Koenig, who's another oral maxillofacial radiologist, and I'm a co-lead in addition to 2 others. So that's the book that we're currently working on, the 3rd edition. That was the first book that we worked on. And then the second one was a dental implants book. And then the third one was the specialty imaging, temporomandibular joint and sleep disordered breathing. And the one that just came out, this sleep disordered TMJ and SDB, this is the 2nd edition. So the 1st edition was purely TMJ, and it was a product of, once again, David Hatcher, taking the time to pass this on. When the student is ready, the teacher will appear. That it was exactly this situation, right? And I was there. He's in Sacramento. I'm here in Florida, and I was basically at his feet, virtually, on a daily basis, to try to get that knowledge that was necessary to create this book, the 1st edition of the book. Okay. And then the natural progression for that TMJ book was adding the sleep disordered breathing, because it's all related to one another, right? And so the whole idea is, once again, I said passion. My passion and my professional goal is to bridge the gap between the different specialties, right? So medicine and dentistry are not speaking the same language. Chiropractic and dentistry are not speaking the same language. Osteopathy and dentistry are not speaking the same language. I'd like to try to create something that helps everyone talk in that same lingo. Because in the end, when we all talk to one another and we communicate with one another, we're able to help our patients better. Okay. Yeah. So there was a lot of lost sleep, I have to tell you. But in the end, the good that we leave behind when we leave this world, whether it's knowledge or good deeds or whatever, that's what my driving force is here. Yeah.
I appreciate that perspective and taking the long view with that, because it's I'm sure there's plenty of times in the middle of working on a project like that it feels like, what am I even doing this for, and who's going to care about this, and all those sort of like low points and just the drudgery of putting something like that together, but it'll live on hopefully college campuses, on their libraries and their bookshelves, and be references for all these standards of care, documents that are being developed and worked on. And as we've talked about with upper cervical chiropractic, there needs to be these seminal works that just help anchor us to a common language and a common understanding. And I think that folks that are not wanting to make a name for themselves in the niche, but are wanting to bridge the gap, I really respect folks like that, because it's maybe a little bit less, what's the word? Maybe there's a little bit less celebrity in it, but there's a lot more karma, to use your word. And I really appreciate that, because the thing is, you'll never know. And this is, you just get philosophical again, like you'll never know the full impact of what this work means to people. And you'll never get to hear from every patient who benefits from the provider who learned through your work. But just knowing that that's, that's out there, and that ripple effect will spread over time is powerful. So I just want to thank you for taking the time, and even if it's a passion project, creating the thing that you don't see in the world that you think the world needs, it's still meaningful to a lot of us. So appreciate your dedication and hard work on that, and I know you'll continue. I know it's not a finished product by any stretch of the imagination, and as time and information evolves, it so will the work.
I'll continue as long as there's breath in me
Yes,
to bring it back
yes,
to Airway.
absolutely, absolutely. Well, thanks again, Dr. Tamimi. I really appreciate it. And if there's any other, last words of encouragement, or things that you'd like to leave the listeners with, last thoughts, this would be a great time for that.
Yeah, just never stop learning. Nobody knows it all, and the more you know, the humbler you become. Okay. So
Beautiful.
if you ever do become a teacher, remember to bow your head before your students, because they're going to be your best teachers.
Mm. And students, as you hear that, students, be willing to throw your hat in the ring too. I mean, you talked a lot about mentors that have influenced you, and I think the life cycle of being a mentee is that then you later mentor others, and you
Pass it on.
perpetuate that curiosity and that love. And it's all, I think humility is the key. You would talk about ego earlier in the conversation. I think humility is the key to progress with this stuff, and I see that demonstrated in you, and I appreciate it. And so on that note, I think it's a great way to wind down. Thanks again for the generosity of your time.
Of course, thank you so much for the opportunity.